just 2 minutes, then I will introduce.
Sure, sure. I'm sorry.
Then
Kunanya, can you show it
at the end?
She has in the
yes,
last.
Yes. So can you see my screen? In the presenter mode or?
Yes. Thank you so much. Yes, I would like to do some announcements from the group. Well, the SIOP Congress is coming to the Netherlands, to Amsterdam, and that's in October. You can still submit your abstracts till April 1st, and there is a specific nutrition part under the supportive care. Well, under the supportive care session this year, so that's the first time. And in addition to that, the day after SIOP, so on Friday, the 24th of October, we have a specific nutrition symposium in the Princess Maxima Center on nutrition. Well, the first invites have been sent already. Well, spaces are limited, so another round will come on later, but it's good to save that date. Another announcement, if you want to receive updates from the SIOP Nutrition working group, you can also become part of the WhatsApp group. That's the second slide. There is a QR code on it, which you can scan if you want to receive updates regarding educational sessions or other news. Feel free to join. And lastly, I would like to already save the date for next educational session, which is on April the 30th, which will be on physical activity interventions in childhood cancer patients and survivors. So these are the announcements from the group. And I will, as I already said, today we have two speakers, and both are affiliated to St. Jude. But first of all, I would like to introduce Dr. Inaba. He completed his medical degree and his PhD at University School of Medicine in Japan. Also received his pediatric training over there, as well as on the Children's Hospital of Michigan. He took his hematology and oncology fellowship at St. Jude, and currently he's a member and an interim director in the leukemia and lymphoma division at St. Jude as well, where he's working in both care and research in children with acute lymphoblastic leukemia. And maybe you have more to add, but that's for you. And I will also already introduce Dr. Kunanya Suwannaying. She completed her medical degree, pediatric training, and also her pediatric hemato-oncology fellowship at Khon Kaen University in Thailand. She also undertook a research fellowship at St. Jude, and she's currently working as an assistant professor in pediatric hemato-oncology at both Khon Kaen University in Thailand, but also a researcher, postdoctoral researcher at St. Jude. And please feel free to add more information on that if you want. But the floor is yours. We are really looking forward to your excellent work on nutritional challenges in acute lymphoblastic leukemia. And I think everyone who wants to ask questions during the talk, you can put them in the chat, or later on you can raise your hand at the end if you want to introduce your question yourself. So the floor is yours. Thanks.
Thank you very much, Dr. Miriam. Dr. Kunanya Suwannaying is from Khon Kaen. I'm from St. Jude. So Thailand, the USA, and then all over the world. It's great to have this communication here. So we're going to talk about nutritional challenge in pediatric childhood ALL. And then these are disclosures. So we're going to talk about on the current situation. We just want to show what's the situation of treatment and acute lymphoblastic leukemia and side effects. And then Dr. Kunanya talked about malnutrition between high-income countries and low medium-income countries, and the impact of nutrition on ALL outcomes and pathophysiology, nutritional assessment method, and BMI height, weight, and body composition change during the ALL therapy, and the nutritional issues in survivorship, and then lastly, we'll propose guideline for nutritional assessment by setting. So let's talk about ALL first. Acute lymphoblastic leukemia is the most common pediatric cancer, which about 20 to 25% are ALL. So I want to show some history of treatment ALL. When St. Jude was built in 1960s, and survival was terrible. Almost, it was death sentence. Or, when we start treatment, survival slightly got better, about 20% in 5 years. But, at that time, relapse happened bone marrow, and the people called sanctuary area, which was CNS, central nervous system, and testis. Therefore, St. Jude incorporated one specific treatment to improve the survival to 50% on top of chemotherapy. Although about 30, 40 years after, they have some deaths we see. The St. Jude, augmented treatment to the central nervous system. There is this diagnosis method for the CNS. This is the CNS3, more than 5 WBC with blast. CNS2, less than 5 is blast. And then RBC, if blood vessels, sometimes we need to go to blood vessels and then introduce RBC, red blood cell plus leukemia cell. We call traumatic tap with blast. So this was a problem in the earlier treatment. So St. Jude started radiation to the brain in the 1970s, 24 gray. As a physician, I feel depressed if we give a radiation to the patient pediatrics. First, in this dark room, and then patient typically sedated, and put in the face mask, this kind of, kids cannot move. I feel so sorry about this, not only acute issues. They have a neurocognitive deficits, IQ decrease, endocrinopathies, growth, sex hormones, so their height is shorter. So at that time, patient, develop obesity because height doesn't grow. And then secondary malignancy, brain radiation can cause another cancer. And then excess rate of mortality, and then decreased quality of life. This is the early treatment. So gradually 1980s, 1990s, survival improved. And then, but earlier still give radiation, patients start dying after 30 to 40 years. So St. Jude, switched to radiation to intrathecal therapy, no radiation. And then now we have a survival of 94%. Cranial irradiation is completely eliminated from the first line setting. And then we have better risk classification, better medication use, especially vincristine steroid asparaginase. This is a slightly complicated picture, but this shows long-term survivors, adults, and what kind of late effects are seen. In the early, when we are giving radiation, multiple organs are involved. And then now we took out radiation, mostly we see musculoskeletal, this blue become more predominant. On top of some gray area, which is the endocrine issues. Endocrine pattern changed before and after cranial irradiation was eliminated. When patient got the cranial irradiation, they had hypothalamic dysfunction, growth hormone or sex hormone, many hormones are not great. These endocrine problems was an issue. Still they see obesity. But later on, after we take cranial irradiation, patients start having glucose metabolism, such as hyperglycemia, diabetes, or body composition change. Again, obesity, because we use a lot of steroid, asparaginase, and vincristine. And then this is a typical ALL therapy as of now. It's gonna change from now, but we are giving this kind of 2 to 2.5 year therapy, induction, consolidation, continuation. We give a tons of steroid around this time, induction and reinduction. So we followed how is the body composition during and after therapy in the ALL patients. Excuse me. At diagnosis, obese overweight is about 25%. After giving induction, this increased to, 15% and 25%. Sorry, 25 and 35%, 35%. So increase after induction. And then we keep giving steroid. This increase to obese overweight goes to almost 50%. And the late maintenance, because we don't use steroid or asparaginase, this percentage decrease. However, importantly, after chemotherapy is done, they develop more again obese overweight, and about 50% are having these issues. During the therapy, I can tell steroid, asparaginase, vincristine, and then sedentary behavior because sick. And then, because of steroid and maybe protective environment, they give unhealthy diet. But this may persist after therapy. Sedentary behaviors, unhealthy diet may persist. That's a speculation to have such a high incidence of overweight obesity. So we have to think about something. This is the current situation. We have cure 94%. We have quite a, obesity is a big issues. From now, what we are thinking, survival is no change last 20 years, 94%. And then now you can do genetics. We can analyze host gene, the leukemia genes, and we can bring a new therapy. We are using old therapy before developed 1980s. These are medications that we are using, but this chemotherapy is survival 94, it cannot improve and has a lot of obesity issues. We can use new medications such as molecular target therapy, imatinib, dasatinib, ponatinib, or immunotherapy, blinatumomab, CAR T cells, inotuzumab. By bringing these therapy, molecular targeted therapy, immunotherapy, we may eventually decrease the dose reduce of the conventional chemotherapy or remove some of the chemotherapy, which may cause a late-term effects. So we will see hopefully some changes from now. However, we have to think about all over the world. Pediatric survival rate in the high-income countries are 80% survival, but there are only 20% of population living there. Low medium income countries still survival as shown here, very low, 30% and 80% population. We have to think about treatment and side effects and globally. So as an introduction, we remove the cranial irradiation, but more steroid asparaginase vincristine. Now we see musculoskeletal, glucose metabolism, and obesity is a big issue now we are seeing now. We need to incorporate new therapeutic strategies. And then this new therapeutic strategy may change long-term side effects. But anyway, we have to think these kind of effort globally. So I'm gonna change to Dr. Kunanya to present afterwards. Just a moment. Okay. I stop sharing. Just a moment. Okay. Dr. Kunanya, please.
Thank you very much, Dr. Inaba, for fantastic introduction. So let's move to global landscape of malnutrition in childhood acute lymphoblastic leukemia. Malnutrition, both undernutrition and overnutrition, is a major global health issue for children. And undernutrition at diagnosis for cancer patient is more common in low and middle income countries, with a prevalence exceed 30% in low income country and exceed 45% in middle income countries and 17% in high income countries. While overnutrition is predominant in high income countries with prevalence exceed 20%. And interestingly, double malnutrition is a condition that combining between undernutrition and overnutrition is rising and more concern in low middle income country, maybe due to processed food access and low physical activity of children. For pathophysiology of malnutrition, in terms of undernutrition side, certain cancer like AML, gastrointestinal tumor, and relapse disease are associated with high risk of undernutrition. And treatment risk factor also play a role for undernutrition, such as type of treatment, like radiotherapy, especially when combining with surgery involving head, neck, and GI tract, can impair eating and swallowing. And all of these conditions maybe result in impaired nutritional intake and some certain side effects of radiotherapy and chemotherapy, such as nausea, vomiting, mucositis, and malabsorption can cause undernutrition as well. In terms of patient demographic risk factors, infant and adolescent are vulnerable group for undernutrition due to increased growth demand. And psychobehavioral factors such as anxiety, depression related to cancer and its treatment can contribute to cancer-related anorexia. So moving to overnutrition side, overnutrition is also a growing concern, especially in children with acute lymphoblastic leukemia or brain tumor, especially when the tumor located at hypothalamic pituitary axis. And treatments such as glucocorticoid and cranial radiation that we use in many diseases, including ALL as well, in some conditions, can promote fat accumulation, reduce muscle mass, and increase risk of future cardiometabolic disease. And genetic factors such as leptin gene polymorphism may increase obesity risk, which can be further aggravated by sedentary lifestyle, as Dr. Inaba mentioned before. And the patient maybe have like this lifestyle during and after prolonged cancer therapy. Both undernutrition and overnutrition significantly influence treatment outcomes. So going to undernutrition can alter pharmacokinetic of chemotherapy, such as methotrexate and vincristine, and can cause increased risk of infection, transfusion support need, and prolonged hospitalization, and associated with inferior survival, especially in relapse disease and ALL patients. For overnutrition, can extend the half-life of chemotherapy, such as cyclophosphamide, doxorubicin, or methylprednisolone, and enhance clearance of some chemotherapy, such as methotrexate 6-MP, causing underdoses or overdoses of chemotherapy and increasing risk of treatment-related toxicity, increasing risk of mortality, and moreover, overnutrition associated with increased risk of future cardiometabolic disease. So moving to nutritional assessment, monitoring nutritional status should begin at the time of cancer diagnosis and continue throughout therapy and into survivorship. A comprehensive evaluation can be divided into basic assessment and advanced assessment. Basic assessment should include screening tools, anthropometric measurement, biochemistry exam, clinical evaluation, and diet history. And these measurements are often sufficient for guiding nutritional management in limited resource setting. But in the setting with greater resources, advanced body composition technique like bioelectrical impedance analysis or BIA, dual energy X-ray absorptiometry or DEXA, CT or MRI can be added to provide more detailed insight of detect early change of body composition. In resource-limited setting where dietitian and physician may not be available all the time or sufficient to evaluate nutritional status for patient, nutritional screening tools are very useful to prioritize patient at risk. The screening tools that we commonly use in pediatric are like nutritional screening tool for childhood cancer or SCAN, STEM and Strong Kids. STEM and Strong Kids were decided for a general like pediatric hospitalization. While SCAN is quite specific to childhood cancer, if you can see all of these questions may be related to cancer treatment. But like all of three questionnaire mainly focus on undernutrition and work best at diagnosis and during active therapy. But it's quite limited to use in survivorship phase because patient is more likely to be obese. When assessing nutritional status in children, weight, height, and body mass index or BMI are commonly used in both settings like low middle income countries and also high income country. Longitudinal growth curve plots are useful for monitoring the growth over time. These measures are typically plotted by using WHO growth chart or CDC growth chart. However, weight and BMI may be affected by cancer-related conditions such as large tumor mass, amputation, or skin edema. In terms of WHO growth chart, there are two charts that we need to consider. WHO growth standard for children under 5 were developed from data across 6 diverse countries based on breastfed infant. And another chart is a chart for children aged more than 5. These charts are based on 1977 National Cancer for Health Statistic growth curve and were merged with the younger one to make continuous reference. So this standard aim to reflect optimal growth, especially in breastfed infant, and is also appropriate for use in resort limited setting because but they may be overestimate undernutrition in some population like US population. In contrast, the CDC growth charts are based on US data collected between 1963 and 1994. They primarily use percentile to define nutritional status. However, extended BMI for age chart and C-score charts are also available to assess extreme nutritional status of patients. While these charts are widely used in US, but they may not accurately reflect the obesity trend in some different population characteristics like low middle income countries. So this slide shows nutritional classification based on WHO and CDC. There are 2 key points that we need to consider when using the chart. The first one, when we considering to use CDC chart, it starts from 2 years of age. Therefore, children under 2, it is recommended to use WHO growth chart instead of CDC chart. And the second one, WHO growth chart for children under 5 are different from the patient over 5. Moreover, the cutoff for overweight and obesity are also differ between age under 5 and over 5. So we need to be careful to use the cutoff point for overweight and obesity in different charts. Another parameter that we can use in addition to weight, height, and BMI is mid-upper arm circumference. Mid-upper arm circumference or MUAC is measured at the midpoint between acromion and olecranon process and typically used non-dominant arm or left side. It's quite useful because it's less affected by abdominal mass amputation or skin edema, and is also positively correlated with fat-free mass when evaluated using BIA and DEXA. And it's quite useful for serial monitoring of nutritional status, especially in resort limited setting. And the tape for the WHO tape to use for MUAC is also available and it's very easy to use. And the reference for MUSC measurement are available by using a WHO cutoff as shown here, or using WHO C-score as well as residential percentiles. Another parameter that we can use for evaluate body fat is skin fold thickness. Skin fold thickness can estimate total body fat, as the most fat is stored subcutaneously. There are many sites that we can measure skin fold thickness, but most common sites are tricep skin fold thickness and subscapular skin fold thickness. And study on childhood cancer during treatment and survivorship demonstrated that tricep skin fold thickness positively correlated with fat mass, as confirmed by BIA and DEXA. Reference available that we can use are WHO percentiles, C-score, as well as residential percentiles. We know that visceral adipose tissue, or VAS, is associated with metabolic syndrome and cardiovascular risk. So waist circumference is a practical surrogate marker for estimate VAT, because VAT is quite associated with the abdominal girth. And international waist circumference percentiles by age and sex for children aged between 6 to 19 years old are available, with value above the 90 percentile associated with increased risk of cardiovascular disease. Alternative parameters that we can use are waist to hip ratio and also waist to height ratio. But please be cautioned when we use waist measurement, because it might be false positive or false value when we use this measurement in some patient with abdominal conditions, such as abdominal mass, large organomegaly, ascites, or the patient undergoing radiation. So moving to dietary assessment. So dietary assessment should evaluate calorie, both macronutrient and micronutrient, and baseline dietary history should be performed and cover eating prevalence, food allergy, eating pattern, physical level of the patients, and also food hygiene. And tools that we can use are 24-hour recall, food frequency questionnaires, food diary, or remote food photography, as shown in this picture. Clinical assessments are essential for detecting signs of malnutrition, vitamin and mineral deficiency in children. Key evaluation should include assessment for anemia, loss of subcutaneous fat, muscle wasting, skin and hair change, skin edema, such as in Kwashiorkor patient, and also sign of vitamin and mineral deficiency, such as perifollicular hemorrhage in vitamin C deficiency, and ectodermatitis, enterohepatitis in zinc deficiency, as shown in this picture. Biochemical parameters can help to assess nutritional status by providing insight into protein status, protein level, organ function, bone health, anemia and deficiency, and also inflammatory process. Please be mindful that these parameters may be altered by cancer or treatment effects, such as like asparagine effect as well. Advanced tests such as retinol binding protein, transferrin receptor may help in severe malnutrition, but are not widely available in all settings. So moving to advanced body composition assessment that we can use in high-income country setting. The first one is bioelectrical impedance analysis, or BIA. BIA use electrical conductivity to differentiate between fat mass and fat-free mass. It's very simple. It's simple and non-invasive and inexpensive, and also high reproducibility and good correlation with the reference method as reported by using like DEXA. And it's quite useful in children with chronic conditions such as cancer, HIV, and anorexia. In terms of DEXA, DEXA measure different in low dose X-ray absorption by bone mineral density, fat mass, and fat-free mass. And it's it's quite accurate, reproducible, quick, and low cost, and minimal radiation. Some report mentioned that DEXA can estimate VAT and SAT, but indirectly because it's calculated by the software. So the result might be vary, depends on device and software calculation. So moving to the CT and MRI. CT and MRI, which are commonly used to diagnose and monitor in malignancy, are also considered gold standard for body composition analysis because they provide three-dimension imaging that accurately differentiate between lean mass, subcutaneous fat, visceral fat, and also intramuscular fat. Single slide CT can be done and measure the parameters such as total psoas muscle, as shown in this picture, that measure like sarcopenia for the patients. They measure single slide CT at the level between L3, L4, and L4 and L5, and calculate the total psoas muscle area and sum them up between right and left to define sarcopenic obesity, to define sarcopenia. And the reference method are available as shown here. And MRI also provide detailed information on soft tissue, including muscle inflammation and fatty infiltration. However, it is more expensive, time-consuming, and may require sedation in younger children. And this figure demonstrates how MRI assess subcutaneous adipose tissue as shown in red, and also the blue color show visceral adipose tissue assessment, and the pediatric reference are available for the children age 6 to 18 as shown here. So moving to change in weight and height and BMI during ALL therapy. So as Dr. Inaba said that obesity is a major concern for pediatric ALL. When considering to BMI Z-score trend, the median BMI Z-score at all therapy and off therapy time point was significantly higher than at the diagnosis except then 19. As the BMI Z-score trend increased, the median weight Z-score at week 21st, 48, and 96, and also 1 year after therapy are higher when compared to at diagnosis. And if you can see after therapy time point, where even though we stop the treatment, where Z-score are continue as higher when compared to at diagnosis. While BMI and weight increase, the median height Z-score declined by week 120. Although some improvement was observed during off-therapy period, but it never returned to the baseline value at the diagnosis. Moreover, factors that associated with lower median height Z-score at 5 years of therapy were observed, including age at diagnosis more than 10 years of age, standard or high-risk status, initial white blood cell count equal or more than 50,000, and also seen disease positive. All of these factors may associated with higher intensive treatment when compared to the other group. In a subsequent analysis of this cohort, who were of healthy weight or underweight at diagnosis, the patient who were aged to less than 10 years old had a significantly higher risk of becoming overweight or obese during or after therapy compared to those with older age at diagnosis. Moreover, to gain insight into BMI body composition change among children with ALL. So this study assessed BMI and quantitative computed tomography or CT with use for bone mineral density measurement in total therapy 15 cohort. And we measure 2 time points at the diagnosis and after therapy. So this study include children with ALL with 189 patients. And the QCT was done at the level L1 and L2. And parameters of interest are subcutaneous adipose tissue or SAT, visceral adipose tissue or VAT, total adipose tissue, lean tissue, and lean tissue to total fat and fat to SAT ratio. For analysis, all parameters of interest were divided by height per meter square to decrease the effect of growth over 2 time points. The first one, we compare correlation between BMI and the body composition value that we observe at the diagnosis and after therapy time point. We found that BMI score correlate positively with SAT, VAT, and total adipose tissue at the diagnosis time point and also after therapy time point. However, median BMI score is negatively correlated with lean tissue to total adipose tissue ratio and negatively correlate with VAT to SAT ratio. So this slide demonstrated that BMI cannot answer like all of body composition compartment. So maybe fall negative to diagnose some condition like sarcopenic obesity. At after therapy, patient had lower lean tissue and higher SAT, higher VAT, and also higher total adipose tissue when compared to diagnosis. Patient age more than 10 years at diagnosis had higher SAT, higher total adipose tissue, but lower lean tissue and lower lean tissue to total adipose tissue ratio when compared to younger age at diagnosis. Female patient had lower lean tissue and lean tissue to total adipose tissue ratio when compared to male patient. Therefore, conclusion from this study, early dietary and physical therapy intervention should be considered since time point at diagnosis, particular for female patients and also patients who age older than 10 years at diagnosis. And this study demonstrates how impact of nutritional status during therapy on status at off therapy and survivorship. So we found that overweight and obesity at diagnosis and higher BMI score at diagnosis were significant predictor for being overweight and obese at the end of therapy. And in multivariate analysis, when adjusted for BMI score at diagnosis, and increase in BMI score during induction and increasing BMI score during maintenance were associated with about 3-fold increasing risk of being overweight and obesity at the end of therapy. And at 5 years post-treatment, overall increase in BMI score from diagnosis to the end of therapy was associated with increasing risk of being overweight and obesity as survivor. From the previous study, ALL survivor has higher risk of obesity. So this study explored with prevalence of obesity, metabolic syndrome, and also cardiovascular risk in ALL survivor and compared to control from in-hand data. So this study include 784 ALL survivor patient with median age around 30 years old, but around 45% of patients had obesity since 30 years old. 33% had metabolic syndrome. Around 30% had fasting hyperglycemia or receiving treatment for hyperglycemia. 44% had dyslipidemia and around 46% had hypertension. And when comparing to enhanced control, ALL survivor had a significant higher risk of metabolic syndrome, hypertension, low HDL, and obesity, and also insulin resistant. After adjusting for BMI, ALL survivor continue to have increased odds ratio, increased risk for low HDL, hypertension, and also insulin resistant. When considering to cranial radiation effect, the patient who received cranial radiation were significantly more likely to have metabolic syndrome, dyslipidemia, and also obesity when compared to the patient who received chemotherapy alone. So ALL survivor had poor body composition and also impaired fitness outcome. So this study enrolled 365 ALL survivors and compared to age and sex met healthy control. So among female survivors who received cranial radiation had a higher percentage of body fat and lower fat-free mass percentage when compared to non-cranial radiation survivor and also healthy control. In terms of male survivors, both those with or without cranial radiation had higher fat percentage and lower fat-free mass percentage when compared to control. So focusing on like fitness outcome of ALL survivor. On average, flexibility, peripheral sensory integrity, muscle strength were lower in ALL survivor when compared to control group. And when considering cranial radiation effect, ALL survivor who received cranial radiation had a lower mean value of like these outcome when compared to chemotherapy alone. Moreover, cardiopulmonary fitness value were lower in ALL survivor than in control group, if you can see here. So in conclusion from this study, there is a need for a diet and exercise intervention to improve body composition and fitness outcome in ALL survivors. Because of effect of malnutrition occur during therapy and also continue to survivorship, and there are a variety of resources available for individual countries. So we would like to propose the guideline for nutritional assessment. We categorize resource setting into 3 levels, including limited access, partial access, and full access based on the availability of biochemical evaluation, body composition assessment, and nutritional support. In resource limited setting, weight, height, BMI with growth curve plot are primary for use for nutritional assessment. However, BMI alone may not be reliable in some cases, such as patients with amputation or large tumor mass. So we suggest to ask screening questionnaires like SCAN and also MUAC to enhance sensitivity to detect malnutrition. If the patient has at least one abnormal parameter, further evaluation and nutritional management should be done. And then we recommend to re-evaluate monthly until malnutrition is resolved. In partial access setting, we recommend to add laboratory assessment since diagnosis to use as a baseline, and then add BIA to measure body composition. And this measurement should be done at least twice at diagnosis and of therapy to identify early signs of adiposity change and sarcopenia. In terms of full access setting, where DEXA, CT, and MRI may be accessible. So we suggest to add like DEXA or CT or MRI in addition to anthropometric measure for provide precise body composition measurement. And advanced techniques should be performed at least twice and possibly during therapy, because some studies mention that body composition change can occur as early as 6 to 14 weeks after therapy initiation. Even though standard cutoff for pediatric sarcopenia and obesity are still being studied, but longitudinal change between certain time point can provide detail and early detection of obesity and sarcopenia. So nutritional assessment should continue into survivorship, as long-term complication can increase the risk of cardiometabolic disease during survival. So in result-limited setting, annual anthropometric measurements are recommended with more frequency follow-up for those with nutritional issues. In partial and full access setting, risk-based anthropometric measurement and biochemical assessment should be performed every 3 to 6 months, depend on nutritional risk of the patient. So in conclusion, nutrition is a key factor influencing treatment outcome in pediatric ALL. And nutritional challenges in ALL patients can arise from diagnosis through survivorship. Comprehensive assessment and appropriate intervention can help reduce complication, enhance treatment efficacy, and improve quality of life. And we might need multidisciplinary team for addressing nutritional challenges and optimize patient care. And standardized care tailored to different settings can enhance high quality treatment and effective nutritional support. So finally, I would like to thank all faculty members at St. Jude for providing me with the opportunity to learn and conduct the research, my institute for their support, and also PsyOp Nutrition Network for opportunity to share the knowledge and work today. And thank you very much, and I'm happy to take any question from you. Thank you.
Thank you so much, Dr. Inaba and Dr. Suwannaying, for this excellent talk, very comprehensive overview. And I think it highlights again how important nutrition is, specifically in the journey of a child with acute lymphoblastic leukemia. I'm wondering if there are any questions from the audience. Please feel free to open your mic, raise your hand, or put them in the chat. I didn't receive any questions in the chat yet, otherwise I can start. I was wondering, I really enjoyed all parts of your talk, and I was wondering if it's correct, like when I saw your slides, first you showed that based on BMI, it seems that being a younger child is increasing the risk of becoming overweight or obese during treatment for ALL. But later on, you said, well, children above 10, so yeah, the older children are more often classified as, well, obese or having more fat mass when it's based on body composition. Is that correct, or can you elaborate a bit more on that, how that's working? How this age effect is actually, it
Yes,
seems,
yes.
yeah.
So let me share the slide again. So if you can see the screen, so I would say this study is different from the other study that we use. So this study, we use the BMI as a proxy of overweight and obesity, and focusing on only the patient with normal weight and undernutrition at the diagnosis. So so I would say from another study that I compare correlation between BMI and body composition. So BMI cannot tell like so many things, cannot tell like some body composition compartment. And in another study we use like QCT to detect adipose tissue. So it might be some effect because we use different parameters to define obesity. So it might cause some different value. So is that answer your question?
Yes, yeah, I think so. I think that's well, what you already said. Well, of course, probably the cutoff values are different, or how people enter the study that might be different, and explaining it. Yeah, yeah.
Yeah, and moreover, we in the QCT study, we didn't subsequent analysis between undernutrition and overnutrition at the diagnosis. So it makes the result different from between two studies.
Yeah, I see. Yeah, so the starting perspective was different. Yeah. Yeah.
As we said, at the diagnosis, BMI is very important. It's carryover, and also even underweight patient gain weight, and BMI is very good, excellent tool. But I think we want to also say is body composition add more meaning in terms of, especially if you can say fat tissue, lean tissue. Lean tissue is muscle, so important to, if they decrease anyway, so it's important to focus on lean tissue as well as fat tissue. If you can divide to visceral fat and subcutaneous fat. Visceral fat is more associated. So I think we are thinking that it is important, if able, it's better to add body composition analysis on top of BMI. It's a common sense, but we are confirming these issues. So that's another comment we wanted to deliver today.
Yeah. Thank you so much, and I completely agree with both of you that adding this information, well, provides us more information, and probably also on outcomes later in life and during treatment as well. I'm wondering, based on your experience both in research and, well, clinical practice, what kind of nutrition interventions or exercise intervention or combined intervention do you expect, or would you first focus on when, well, all the money was available, based on your information?
Dr. Kunanya, you want to answer?
I think the easiest way to intervene during treatment, it might be dietary intervention, maybe easier than exercise intervention. But as far as I know, there is a systematic review talking about like exercise intervention for children, for ALL children. And I would say limited study for exercise intervention can be done just only like for study as I remember, and very duration and also intensity for the exercise, such as like sit and reach test or grip strength or something like that. And but I would say some of study can intervene since after diagnosis, but maybe need like longer duration of exercise intervention, and also like some more frequency than some study that intervene after maintenance because of feasibility during treatment or illness of the patient, something like that. So I would say like dietary intervention might be easier to intervene, but it might be more benefit if we add exercise intervention in addition to dietary intervention as well.
I maybe added, both are important, and also maybe we can use, some computer software technology to maybe monitor remotely if, human interaction is very difficult. So we can add something software. We are thinking that in the early during the induction, both nutrition and physical therapy. And as a leukemia physician, I want to, also we need to change the treatment. Actually, we are using a lot of chemotherapy, especially steroid makes, totally change during the induction. So St. Jude is trying to remove asparaginase, decrease the steroid by bringing a more immunotherapy. We have many tools to treat leukemia. It's going to change next 10 years at ALL treatment by using less toxic, more immunotherapy. Hopefully immunotherapy doesn't affect the other side effects. But I think next 10 years, we will see many change, not only in the intervention, as well as treatment. That's I want to deliver today as well.
Thank you so much. And I think we all are looking forward to what the future may show us. And I agree with you. And also nice to have your expertise on this specific part of acute lymphoblastic leukemia, which might definitely change the perspectives also regarding overweight and obesity. That would be so nice. So that's I think a nice closing remark. I would like to thank you all again for joining us today, and thanks for the speakers for their excellent talk and being here with us today. Yeah, I think it's time. Yeah, before they close the room, I will close the session. And once again, thanks to all of you, and maybe see you next time.
Thank you. Thank you very much for
Thank you
opportunity.
very much.
You're welcome. Bye-bye.
Bye-bye.